about health assessment of the abdomen. Of course, you need to be familiar with all the structures and organs in the abdominal space. Make sure you know where the following organs lie, their approximate shape and size. The liver, stomach, gallbladder, spleen, small and large intestine, bladder, and the uterus. Some of these organs are considered solid and some are hollow. And by solid in this case, we mean that they keep their shape, and hollow means that their shape changes somewhat depending on the contents. Now, one exception to that rule is the uterus. It's a really muscular organ, and although if it's pregnant, it's going to change shape and size, generally speaking, it's very solid because of all the muscle that exists in a non-pregnant or non-gravid uterus. There are two main ways of landmarking our findings in the abdomen: the quadrant system, and then there's a 9-grid system. The more modern and common method at this point is using quadrants, which is pretty simple: right upper, left lower, right lower quadrants, divided approximately at the umbilicus and the midsternal line. You might see these abbreviations, right upper quadrant versus upper right quadrant, but it's the same idea. The somewhat older system that you might still see referred to, so it's a good thing for you to know these words, is this 9-region method. If you think about it, it's not actually quite that hard. The umbilical region, of course, is surrounding the umbilicus. The epigastric region, if you look at the root, gastric means stomach, and really that's where the stomach is. Epi means around. The right and left hypochondriac regions. Sounds like a psychological disease, right? But no, chondria in this sense means it comes from cartilage, and that's referring to the cartilage between the ribs. So if you think about the left and right hypochondriac region, it means just below the ribs, sort of at the rib edge. The right and left lumbar region makes sense because it correlates to the lumbar area of the back. The left and right iliac region makes sense because they're right around the iliac crest of the hips. The one region left over is a hypogastric area, or the suprapubic area. Now, hypogastric doesn't make a whole lot of sense because gastric, as you know, means stomach, and hypo means below or less than. It's a lot more below. It's inferior to the umbilical region. So that's not quite so logical. It's also sometimes referred to as the suprapubic area, which makes a little bit more sense. Now, I want to make sure you know Dr. Roberts' pet peeve number 43, the stomach is not a synonym for the abdomen. The stomach is an organ that lies inside the abdomen. In common parlance, of course, people use the word stomach when they mean the whole abdomen. But as a nurse and as a nursing student, you really need to be distinguishing the two things and not using stomach when you mean the abdomen. If you're talking to a patient and you want something a little less technical than the word abdomen, you can use the word belly. But if you use stomach, or you see the word stomach in a test, it means the organ. If a nurse says that a woman has a baby in her stomach, for instance, you don't need to call the midwife, you need to call the cops. Please don't get stomach and abdomen mixed up. Let's talk a little bit about the history that you're going to take for an abdominal concern. One thing that we want to ask about is the last time that someone had a bowel movement, or BM as commonly abbreviated in nursing notes. Because if it was a very long time ago, maybe something's going on, so we want to know when the last time was. Has this person experienced diarrhea or constipation? And we'll talk a little bit about how we're going to define constipation. Are there any unusual characteristics of the bowel movement or stool? Does this person have any abdominal pain or other pain? Because pain elsewhere in the body sometimes can mean that something's going on in the abdomen. Has this person lost any appetite? Do they have a good appetite? The fancy $2 word for loss of appetite or lack of appetite is anorexia. We think of anorexia as that psychological disease, anorexia nervosa, but anorexia itself just means the symptom of loss of appetite. Dysphagia means pain or difficulty with swallowing. Phasia means swallowing, and dysp, as you know, means pain or difficulty with. Has this person experienced any food intolerance? If so, what is the reaction? What kinds of foods or liquids cause that reaction? Has this person had any nausea or vomiting? You should know the abbreviation N/V for nausea, vomiting. Has this person had any heartburn? The fancy $2 word for that is pyrosis, or a lot of unusual burping, more so than usual. Fancy word for that is eructation. You want to do a nutrition assessment, and there's lots of different ways to do nutrition assessments. Some of them have advantages and disadvantages. If you want to do a 24-hour recall, that's a common way to do it. Say it's noon now. You're going to ask someone what they've eaten or drunk since breakfast. Anything that they've eaten or anything that they've drunk, you're going to write down what it is, and as well as you can, estimate the quantity. What did they eat or drink for breakfast? Did they eat or drink anything before breakfast? And then overnight, did they eat or drink anything? Take down what it was and the quantity as best you can. Before bed last night, after dinner, what did they eat for dinner? Any snacks that they had before or after dinner? anything that they ate during the afternoon, what exactly did they have for lunch, and you move all the way back to noon the day before, and that's your 24-hour recall. Now, it may be that they had an unusual day in the last 24 hours for their nutrition intake, but if you look at it statistically, a 24-hour recall is going to be fairly representative of what most people are eating most days. Another way to do a nutrition assessment is to ask a patient, how many servings in a day do you have of red meat? How many servings a day do you have of fruits, vegetables, whole grains? How many cups of water? How many cups of coffee, etc.? Now, the problem with this is that people don't always keep good track. We may think that we're eating a certain amount, but that's not actually the truth of what we get. It may be influenced by what we think we should be eating. Oh, of course I eat 5 servings of fruits and vegetables every day. And no, I rarely have anything sweet. May not be that they're lying, but that we don't really track very well what we put in our body. Another way that someone can do nutrition assessment is a nurse can ask a patient to take a log of what they eat. So for the next 3 days, you're going to write down everything that you eat and drink, how much and what it is and what time, and then come back in 3 days, 4 days, and we'll have another meeting and we'll discuss it. Now, that can be really accurate if someone is proactively writing down what they're eating and drinking. On the other hand, it might influence what that patient is taking into their body, because if I know somebody's going to be looking at my log in a few days, maybe I'm not going to eat that Three Musketeers bar I might have wanted, which could be a good thing or a bad thing, depending on how you look at it. But in some way, you want to try to document what this person is eating and taking into their body. Very often, nutrition assessment can be a great time to do some education. When someone is talking about the various foods that they eat, you may ask, well, and what kind of nutrients do you think that tomato soup has in it? And it may be a really good time for them to tell you what they know and maybe fill in some of the gaps. So assessing knowledge and also doing some teaching. We want to know if this person is menstruating, when was their first menstruation? Menarche means the age at first menstruation. We want to know their LMP, which is last menstrual period. LMP specifically means the first day of your last bleed. So if someone started bleeding last week, you might say the 15th of December. Or if your patient started their menstrual period this morning, today would be their LMP. If they haven't bled for 10 years because they're menopausal, you don't need to get it down to the day, but a year or a month perhaps if it's been a few months. We want to know if they're regular in their periods. So 28 days is sort of exactly what's considered regular. Now, most human beings don't bleed exactly every 28 days. We're not made like that. But anything between 21 days and 35 days is considered regular. So if I'm having a menstrual period and there's 25 days between the first day in February and the first day in March, and then the first day in April was 31 days after that, that still counts as regular, as long as it's between 21 and 35 days. And if someone has an irregularity, get them to describe that and track it. There are a lot of apps for this, or someone can just write it down. Does this person have a great deal of trouble with their periods? Dysmenorrhea is the fancy $2 word for really difficult periods. Now, most people have some amount of cramping with menstrual periods, at least some months. But dysmenorrhea means there's so much pain or other problems that that person can't get their work done. They can't attend school, they can't go to work, maybe they're curled up in bed. It's very often severe cramps, but also people with dysmenorrhea sometimes can get nausea and even vomiting. Some people can lose consciousness and faint with dysmenorrhea. So dysmenorrhea is more than your average just uncomfortable menstrual cramps. What are the other things we're going to get in an abdominal history? As usual, we want to know past medical history. Specifically think about the biggies like diabetes, cancer, heart disease, liver disease, thyroid disease, but also think a lot about abdominal concerns. Does this person have a history of heartburn, ulcers, gastritis? Have they ever had appendicitis? Have they ever had gallstones? Have they ever had mononucleosis, hepatitis, inflammatory bowel disease, or colitis? Have they ever had surgeries, an appendectomy, a splenectomy, a laparoscopy of some kind, hysterectomy? We want to know this person's family history, especially as related to abdominal concerns, but also the heart disease, the diabetes, the cancers, infections. We want to know what medications this person is on, as always, prescription, over the counter, and home remedies, vitamins, supplements. We want to know what allergies this person has and their reactions to those things, allergies to foods as well as allergies to medicines. We want to get a full review of systems. So think about every system of the body besides the abdomen. Anything might be related. We want to capture that. Let's talk a little bit about characteristics of stool. So we want to know about the color of the stool. Clay-colored stool is a funny word because honestly, in different parts of the world, clay is all different kinds of colors. But in this case, what they mean by clay-colored stool is sort of a beige gray, off-white beige grayish color. And the fancy word for clay-colored stool is acholic. acholic, acholic stool. Acholic stool implies that something's wrong with the gallbladder because the gallbladder should be secreting bile into the small intestine. And as it does that, the bile tends to color the stool that dark brown. If that doesn't happen, then you're going to get a blonde or clay-colored stool. Melena or melena refers to blackish stool. Now, you can sometimes get black-colored stool because of certain foods or certain medicines that someone is taking. But it also could be a sign that someone has a GI bleed, and it tends to imply that there's a GI bleed in the upper GI system. So if I'm bleeding in the esophagus or the stomach, that acid from the stomach is going to turn that red blood into a more blackish color, almost a coffee ground, dark brown, blackish. And so if you have melena in the stool, it could mean that you have a bleed high up in the GI system. If you have a bleed lower down in the GI system, in the small intestine, the large intestine, colon, the rectum, or the anus, you are more likely to have a red streaked stool or something that looks a little more like blood in the stool. So could that be a hemorrhoid? Could it be colon cancer, trauma? Any of those things is possible. Could be lots of things, but it's a hint as to what might be going on. Does this person have loose or hard stools? If they're having diarrhea, you want to distinguish between soft stools and watery. Watery stool can be quite dangerous if prolonged. Is there a difficult or painful passage of the stool? Is the stool floating in the commode? If a bowel movement is floating in the top of the water, it implies that there is fat in the stool that's lighter than the water, so it makes it floating. The fancy word for floating stool is steatorrhea. Steatorrhea implies that fat from the food that should have been absorbed in the digestive process was not absorbed for some reason and remained in the stool, which is why it ends up floating, being lighter than water. Let's talk about constipation for a minute. Constipation actually has 3 different definitions. So someone who is moving their bowels less frequently than normal has constipation. It turns out people have different patterns of bowel movements. Some people have 1 bowel movement every day, some people have 2, some people have 1 every other day, etc. So if you're talking to a patient who usually has 3 bowel movements every day and now they're only having 1, that may not sound like constipation from some perspectives, but for that person it is constipation. And so that counts as one of our definitions of constipation. No matter how often a person normally moves their bowels, if it's less than 3 times a week or less than once every 3 days, that would be considered constipation, even if it's that person's normal. The third definition of constipation is if there's hard or painful passage of the stool. Now, speaking of pain, one thing to understand about the abdomen and much of inside the body is that we experience pain inside the body differently than experiencing pain on the outside of our body. Our skin tends to be very sensitive to touch and to pain. And that makes sense. As we're moving through the world, this is our protective organ. And we want to be able to sense exactly if we're getting hurt. If we're running through a briar or something and something scratches us, we need to know that. Our pain nerves inside our body don't work the same as they work on our skin. Imagine someone were poking your gallbladder with a pen. You're not going to feel that exactly and say, oh, I know exactly where I'm being poked, in the gallbladder. It doesn't feel like that. If you have menstrual cramps, it doesn't just happen in the tiny little area of the uterus. It kind of fills up the whole lower abdomen. Referred pain means that we're experiencing pain in an area different from that of its origin. So if I have damage or pathology going on in one organ, I might feel it in another place. For instance, if I have an ectopic pregnancy, meaning that there's a pregnancy in my fallopian tube, I might feel it in my fallopian tube, but I might also feel it in my shoulder. People are used to the idea that if I'm having a heart attack, I might feel it in my jaw or my arm. It's the same idea. That's referred pain. So when thinking about the abdomen, remember that pain anywhere in the body might be related to something going on with the abdomen. Let's move on to the physical exam of the abdomen. The abdominal physical exam is one of the exams that's really important to do in a particular order. We want to inspect first, then auscultate, then percuss. We're going to do light palpation and then deep palpation. The main reason why we want to do it in this order is we want to auscultate before we touch the patient, particularly before we palpate the patient. And the reason is that one of the things we're listening to is bowel sounds. And if we push on the belly, we can actually increase the frequency of bowel sounds. And we want to know what those bowel sounds sound like before we are stimulating them. And the second reason why this particular order of physical exam is important is very often if someone is getting an abdominal exam, they're experiencing some sort of pain. And palpation may evoke more pain. If a patient is going to experience more pain or increased pain or pain at all during the exam, we want that to happen at the very end of the exam. So then they don't have to continue putting up with us as we're examining them. So if something's likely to hurt, we want to put that at the very end and have them comfortable throughout the majority of the exam if we can. First, you're going to inspect the abdomen. As always, you're looking at the skin. You're always doing a skin exam. So we're looking for scars, wounds, striae, lesions, rashes, discolorations, lumps, bumps. If someone has a wound, you want to document exactly how it's healing. What colors do you see? Is there exudate? Is it dry? What's the size? What's the shape? Get out your ruler, get out your light. We're also going to look for the contour of the abdomen. To assess the contour, you need to crouch down beside the patient and look across their abdomen, perpendicular to their body. These are the 4 categories of contour that we use: scaphoid, flat, rounded, or protuberant. We want to look from the foot of the bed to see if that abdomen is symmetrical. Is there something on the right that's much different than the left? The nurse is also going to use their power of inspection to look for guarding. Many times when someone is experiencing pain or worried that they're going to experience pain, you're going to see it in their face, okay? And or the way they hold their body. So they might be moving through the room very carefully and slowly and guarding their abdomen so that they're not jostling around. We're going to look at the umbilicus. Is it inverted? Is it everted? Is it herniated? Is there a wound from surgery or piercing? If so, is it well healed? Is it swollen? Is it red? Look for a pulsation of the aorta in the abdomen. You may see it in these areas. Normally, you might see a very small pulsation. However, if there is a mass of some kind, perhaps right over the aorta, you might see that pulsation transmitted through the mass, and it ends up being a lot larger than you would expect on the abdominal surface or in another area. So note that. Next, we're going to auscultate. For this whole exam, think about those 4 quadrants of the abdomen. Each of these techniques, you're going to start in the right lower quadrant, move to the right upper quadrant, left upper quadrant, and left lower quadrant. You're on the patient's right side, and you're moving in a clockwise direction. First, we're going to auscultate, then we're going to percuss, then we're going to lightly palpate and deeply palpate. So basically, you're making 4 trips around the clock during this exam. And we're going to auscultate 2 things: bowel sounds and vascular sounds. Why do you think we listen for bowel sounds? Well, as it turns out, some diseases and disorders can create paralytic ileus, or the cessation of digestion. If that's the case, we really need to know it for lots of reasons. So paralytic ileus means that the peristalsis, or waves of digestion in the intestine, stop. They can either slow down or they can stop. Now, ileus is really important to identify for a number of reasons. One of which is we don't want to have that patient ingest anything while their gut isn't working, because it can come right back up. It can also end up in the lungs, causing a pneumonia or very serious complications. Another reason that we see paralytic ileus is actually some of the drugs that we use. For instance, general anesthesia stops the digestion peristalsis. So if you have a patient coming out of general anesthesia in the recovery room and they want to have something to drink because they're feeling really thirsty, you're going to want to make sure that their gut is working before you give them anything to eat or drink. And how you're going to do that is you're going to listen for bowel sounds. So you're going to listen in each quadrant and decide on how frequent those bowel sounds are. So bowel sounds are very easy to hear. You can use the diaphragm, you can use the bell. They're usually pretty loud, and they're not hard to identify even for a student. It's a gurgling sound. So think about how often you're hearing gurgling. If within 1 minute you hear between 5 and 30 gurgles, that's considered normoactive bowel sounds. So be careful not to use the word normal. It's not normally active, it's normoactive, one word. If you hear more than 30 gurgles in a minute, which means pretty much constant gurgling, that would be called hyperactive bowel sounds. If you hear less than 5 gurgles per minute, then that would be hypoactive bowel sounds. What's probably most important is to differentiate between hypoactive bowel sounds and absent bowel sounds. And in order to do that, you're going to need to listen for a full minute in every quadrant before you can decide that that person has absent bowel sounds. If they have just 1 bowel sound in 1 quadrant within a minute, that would still be considered hypoactive, but not absent. Now we're going to use the bell to listen to see if we hear any bruits on the aorta, the renal arteries, or the iliac arteries. Listen carefully and see if you hear this low-pitched sound that would be in the rhythm of a pulse. It might be whooshing or tubular. It's usually something like shh, 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 shh in a low pitch. So you're going to listen over the aorta. Remember, the aorta comes out the heart this way, curls around behind it, and comes down here. So you can feel a pulse here, and you can listen with your bell. Now remember, with a bell, you're going to use a very light touch. Don't press down hard, otherwise you're turning it into a diaphragm. And if that bruit is there, you might miss it because it should be a light touch, a low-pitched sound. You're going to listen over the renal arteries, which is to say superficial to the renal arteries, and the iliac arteries. Sometimes you'll see texts listening for the femoral arteries too, to see if there are any femoral bruits. For the context of our class, I'm going to ask you to listen to these 5 places. Remember, you're listening to see if bruits are present or absent. If you're not listening correctly, for instance, if you're using the diaphragm, you might miss one that's actually there. If you have your stethoscope in the wrong place, you won't know if you've missed it. So be careful it's in the right place. Now we're going to move on to percussion. We generally use indirect percussion on the abdomen to put vibration into the abdomen, and it creates a sound that helps us understand the density of tissue underneath it. And that helps us in a number of different ways. It can help us detect if there is a solid mass, tumor, constipation, a solid organ that's larger than it should be, organomegaly in an area. If we hear tympany, we know that there's gas, which might be extra gas than we expect, or gas in an area we don't expect. So to be able to use vibration to hear a sound that helps us understand what the tissue density is underneath our hands. Start in the right lower quadrant and move in that clockwise manner around the abdomen. Notice the general sounds. Now, people have lots of different percussion sounds in their abdomen. There are going to be dull sounds. There'll probably be resonant or hyperresonant sounds. There might very well be tympany. Flat isn't quite so common, but I suppose you could find some flat areas if you went to the hip, for instance. But there's often going to be a mixture of sounds, depending on what's going on in the gut at the moment. So we're going to move in that clockwise manner to listen to the general sounds of the abdomen. And then we're going to also use indirect percussion to find the span of the liver or the size of the liver. Now, this has to happen at the right midclavicular line because, as you know, that liver is sort of a triangular shape, and it's wider at the lateral aspect and pointy, smaller around the midsternal line. So we have to decide where on this length we're going to be listening. So at the right midclavicular line, that's where you're going to percuss. And you're listening for dullness because it's a solid organ. You use percussion to hear where it changes from the guts, which will probably be like a resonant or hyperresonant sound, and then it'll suddenly turn dull at the lower edge of the liver. And above the liver, you're going to hear the resonance of the lung. So make sure you move the breast out of the way, make sure you're underneath the bra, and percussing from the lung down to the top edge of the liver, and you'll hear dullness. Then measure that span, again, at the midclavicular line, not too far lateral, not too far medial, but at the midclavicular line, how many centimeters does that dullness of the liver extend? In an adult, it's usually between 6 and 12 centimeters. A really short person, it's going to be closer to 6 centimeters. A very tall person, it's going to be closer to 12 centimeters. If it's more than you expect, what might be going on? Hepatomegaly. Now, there are lots of other ways to assess the liver, but for the time being and for the NCLEX, this is pretty much what you need to know for physical exam. We're also going to use percussion, usually blunt percussion, to give a gentle tap, a little gentle punch to the kidney area at the costovertebral angle. So the costus means the ribs, the angle of the ribs, and the vertebra, the angle between the vertebra and the ribs is called this costovertebral angle. And if there's tenderness to percussion at the CVA, that's CVAT, costovertebral angle tenderness. That's a sign that maybe something's going on with the kidneys, like, for instance, pyelonephritis. You can do the costovertebral angle percussion before or after the rest of the abdominal exam. You probably don't want to sit them up from lying and then have them back lying down. So either do it at the very beginning or the very end. The rest of the exam is palpation. First, we're going to do a light palpation, then we're going to do a deep palpation. For light palpation, for an adult, that means about a centimeter of depth of pressing down. Now, we're feeling to see if there is guarding or rigidity of the muscles. We want to feel a soft abdomen. If there is very hard rigidity in the abdomen, not just being muscular, but hardness of the abdomen, like a board, that's an emergency. It's a sign of acute abdomen, and that person may need surgery right away. So hopefully there's a soft abdomen. Ask your patient to relax their muscles if they can. Sometimes it can be ticklish, but honestly, ticklishness happens a lot more among classmates than it does between a nurse and a patient. So you might find it harder in lab than you do in real life. We're going to use light palpation again in that clockwise manner, starting in the right lower quadrant, assessing for tenderness and large masses. The light palpation gives you the lay of the land, whereas deep palpation is going to give you a more detailed picture of what's going on in the abdomen. Press down something more like 5 to 8 centimeters deep. If you're a small person and your patient is large, you may need to use 2 hands and push with your upper body down. If your patient is feeling ticklish or your lab mate is feeling ticklish, you can actually put their hand on top of your hand, and when you press down, their brain will think it's their hand pressing into their own body, and it won't be as ticklish. For deep palpation, we're assessing for the details of masses. We can feel for the liver extending down past where we think it might be, the spleen, which is usually up here. If it's enlarged, splenomegaly will grow in this area. And so you might use deep palpation to find splenomegaly. If you find a mass, make sure you describe the size, shape, the location, whether or not it's tender, the consistency. So does it feel hard or soft? Is it freely mobile or is it fixed? Is it pulsing? Is the surface smooth versus rough or bumpy? And lastly, we're going to assess for rebound tenderness, or RBT. So to perform RBT, we're going to push deeply into the abdomen and then release quickly. And the sudden or quick release is really crucial to make the rebound tenderness test. We really want to distinguish, does it hurt more when you press in or when you let go suddenly? If someone has more pain when you let go suddenly, that's called positive rebound tenderness. And again, it's a rather acute sign. It generally means an emergency like appendicitis or peritonitis. That person needs further assessment ASAP. When you do palpation, use the pads of your fingers. Don't poke down like this, but use the pads of your fingers and move them in a circular motion. One thing you can do, because people sometimes expect some pain with palpation, you can use your stethoscope to gently press down right after you auscultate, before you percuss. You can gently press down with your stethoscope just a little bit, because people may expect pain when you palpate with your hand. They may not expect it with a stethoscope. So sometimes, although they're not necessarily trying to fool you, the anxiety may create more pain. So if someone, for instance, does not have pain with light palpation of the stethoscope, but does have pain with the same amount of palpation with the hand, that's another data point that you can put in your equation. A lot of abdominal pain may have a psychological component. That doesn't mean that they're not in pain. It doesn't mean that they're lying to you or making it up. But we know that anxiety tends to make pain worse. If you've taken a good history, you've done inspection, auscultation, percussion, light and deep palpation, you've got a lot of great data that will inform the next decisions about this person's abdominal health.